Professor Jukka Peltola from Tampere University.
Okay, thank you, Sander, and good afternoon to everybody. I'm an epileptologist from Tampere University, and a little bit inspired by yesterday's comments made by Professor Slater describing like how to do your disclosures during yesterday's masterclass. I'm proud to now highlight that my main disclosure for this study actually is that I'm also a co-founder and the medical director for Neuro Event Labs, who is the kind of the creator of this Nelli system. Okay, a couple of words about this Nelli system and setup. Well, step one, camera or one or more are brought to the patient's house and start recording, and there's also a microphone involved there. So these video and audio recordings are analyzed fully automatically, nearly in real time by AI algorithms, creating classified events that are suggestive of epileptic seizures or non-seizures. Supervised learning has been used based on the accumulation of the seizure data to further improve these algorithms. So this is a learning system, and it gets better over time. Then at the stage 3, these events created by AI system are reviewed by a health professional with a video EEG technician training. And then a report is created and sent to a clinician to report about the number of type of epileptic seizures and other significant events. And there at the stage 4, you can also see that there's this kind of interactive user interface with these red and blue dots representing individual seizures. And for the physician, it is a possibility just to clicking on those red buttons to look at every seizure that has been registered. Okay, so as a background, Nelli has been used in some Finnish hospitals since 2017 as part of their routine clinical practice. And quite recently, it has been given a national recommendation for this use of Nelli system by a government-set the National Coordinating Group of Drug-Resistant Epilepsy in Finland, based on both published and unpublished data, also including data from now completed validation studies using video EEG as a gold standard performed by Professor Benitsky and Professor Sperling. So, and this is basically a retrospective real-world study looking at what happened like in those patients that undergone Nelli-registration, what were kind of the clinical outcomes based on retrospective patient record study. Altogether, 104 registration, 104 different patients. There were several patients that got more than one registration, but for the purpose of this study, only the first one was selected. Most of the patients, they came from Tampere University Hospital, and that is also reflected in the kind of the let's say characteristics of the patient included in the Nelli-registration, kind of having a very refractory population. And then there were 3 smaller hospitals who have full neurology service. And then we look at the indications for video monitoring with Nelli, and actually this has been taken one study looking at the clinical utility of video EEG registrations and looking at their indication. So first, there's this differential diagnostic kind of aspect to determine whether the spells that are suspected to be epileptic really are epileptic or not. So just like the differential diagnosis. And then kind of the second part is determining the seizure semiology and trying to classify the seizures and also count the seizures. And as a third kind of indication is that this system has been used as evaluator of the effect of the clinical intervention, either just prior or during the Nelli-registration. And we have our 104 patients, and you can see the clinical characteristics here. So 1/3 of them have intellectual disability. More than half have undergone video EEG registration, so we know about quite a lot about their seizures already, but not in all patients. 92 had a prior diagnosis of epilepsy. And then regarding the epilepsy type, you can see that the patients with extratemporal lobe epilepsy and multifocal epilepsy are the largest groups here. Again, just reflecting the nature of the kind of the method here, because we kind of started looking at the nocturnal seizures only, and then it was expanded that you can also look any other location in the house, and you can have you don't have to have only the emphasis on the nocturnal seizures. And the mean number of registration was 29. So from these 104 registrations, that came to almost 3,000 days altogether, and during those 3,000 days, more than 2,500 seizures were registered. And in 80% of the registration, some clinically significant event was recognized. In 15% of the patients, there were non-epileptic events that could be psychogenic non-epileptic seizures or some sleep-related arousals or something else like physiological myoclonus and so on. And in 65% of the patient, epileptic seizures were registered. And when you look at what were the most frequent seizure types with these focal aware motor seizures, actually 29% had quite minor motor seizures, and that is also reflecting that maybe that because we have so many patients with intellectual disability that have multiple seizure types there. But regarding to more disabling seizures, we had quite a lot of patients with hyperkinetic seizures, and of course we know that many of these frontal lobe seizures, they occur predominantly at nighttime. We had 6 patients who had tonic-clonic seizures. So again, there was a mixture of seizures, and of course not all of the seizures are as relevant, and for the clinical evaluation, usually the more severe seizure types are taken into consideration when doing evaluations about the let's say, therapeutic interventions. So we look at 3 different utility measurements of Nelli-registration. First, how did it affect the clinical decision-making, and then what kind of therapeutic interventions were done after Nelli-registration, and how many patients went to have video EEG registration after Nelli. And now, when we look at these outcomes of Nelli-registration for the clinical decision-making, you can actually see that the most important kind of decision has been based on what we've been discussing all day here, starting from the first lecture by Professor Schulze-Bonhage, just demonstrating that how little we know about the patient's seizures, and many of the presenters and discussions have been mentioning that there's this darkness regarding what we know about the seizures in the patients. And if you don't know what type of seizures patients have or their severity or number, it's very difficult to make treatment decisions and also decide about what to do next year. So in half of the patient that there was this uncertainty, the need for therapeutic intervention based on the recognition of clinically important disabling seizures was made. On the other hand, in 12 patients, there were the need to change the treatment plan was excluded. And again, this is something that we have been discussing already before, that the kind of the negative finding that you don't have seizure if you have been assuming the patient has seizure, actually it's an important outcome there. In 11 patients, 13 patients, there was confirmation about the therapeutic efficacy of an intervention, either prior or during the registration. And 11 patients, there was a change in seizure classification. For instance, that patient was thought to have epileptic seizures, they don't turn out to be non-epileptic seizures, or a new seizure type was discovered based on unequivocal clinical features. And in 14 patients, the registration was unsuccessful. That didn't help in clinical decision making. And what was done? Of course, most of the adjustments were made for anti-seizure medication, in some patients to the VNS or DBS settings, and in 17% of the patients, there was a recognized a need for more active therapeutic kind of approach, and they went to pre-surgical evaluation, and in some patients who had undergone already pre-surgical evaluation, and we were planned for implantation, for instance, with vagus nerve stimulator or DBS stimulator, the patients were screened to have a baseline before the intervention. And in 1/3 of the patients, there was no change in therapy. But on the other hand, that by itself, it's not a negative outcome for the most of these patients. But in these 14 patients, there was like really no significant help. And 9 patients went to have video G, 3 for the diagnostic purposes, and 6 for the pre-surgical evaluation. Okay, as a conclusion, we can say that this real-world data highlights the point that this objective seizure count method, looking at the seizures happening at the patient's home, can help in therapeutic decision making and further make use of helping the patient, and also solving some diagnostic problems there. Of course, the limitations are that this is a retrospective study and we don't have any control groups, so we don't really know what would have happened without the Nelli system. And of course, like now we're also discussing that these kind of home monitoring system, you can also like register these in order to optimize the use of the video G, when you know that how many seizures the patient have and whether it's a good candidate for that 4 or 5 day registration. Again, the point has been made several times today. So I'll thank you for your attention.
That more than 50% of the patients changed management, but was that useful?
Yeah.
So have you followed up on that?
Well, that of course there's always a question like if we have refractory patients, like how many interventions are useful, and of course it's a good question, but for just purpose of this study, we only look at like what was the the limitation of our therapies and treatments, and but actually we are going to analyze the ones who were analyzed like several times, looking at the treatment effect. So in order to try to answer to your question then.
Any other questions from the audience, Andreas?
Yeah, thank you. I think that's extremely interesting to learn more about seizures and semiology that happens at home. One critical question. So we have patients who take just standard surveillance monitors, which you can buy for, I don't know, 50 euros for outside the house, to see if there is any movement around and turning on a light, for example. And there we have some people who have managed to then tape something like their recordings based on such a very simple camera. So what would you respond to? In which way is your system better than that? What does the algorithm for seizure detection do beyond just movement detection? So what is exactly being done by the algorithm, and how much work is left in the system to the later visual analysis?
Yeah, well, of course, this is like a good question, because it's basically if you are like just like recording movement, and then if you check every movement that happens, then you can check every behavioral seizure. But on the other hand, then of course it's like time consuming, and there's this again like this scalability aspect of that. On the other hand, now these algorithms, they have been kind of evolving, and they are looking at specific kind of movement patterns that are suggestive of not only that there's some movement, but also like recognizing some movements that are typical of some seizures and not typical of let's say non-seizure events there. So that is and then of course there's also the thing that most of, like, let's say, the duration of the recording there, you can get quantitative and also like you can measure the duration of these different events there, and looking at the scale of the duration both at the ictal and post-ictal things. But the algorithms, they are getting better all the time, and now they are already classifying different type of seizures there. So that's basically my answer.
Thank you.
One last question to this.
Thank you. How does Nelli distinguish between two people, if there are two people in the camera? And how does Nelli identify non-epileptic seizures during the day? Yeah, well, the daytime, it kind of depends on now the surroundings. You can say that if there is, like, let's say, if the patient is staying in some same location, then it's also possible to use Nelli for let's say, seizure detection. Of course, then the ability to distinguish from, let's say, from normal movements is much more difficult, and this is a kind of process that is ongoing and again improving. And there, for the daytime events, there's more kind of need for this kind of this human interaction, where you can always check whether this is you know, who's the person who's having the seizure. And also, like, we know we have like cats, so that can be, you know, jumping in and out of bed. So, but there's also that, okay, that it's quite easy to kind of just like you screen it and you see that that's a cat and not the patient, and therefore that kind of identifying the right person is possible, because we have always the video as a validation, so you can look at that.